Todos los que nos acompañan esta mañana. Bienvenidos a la reunión regional Avances y Desafíos en Salud Sexual y Reproductiva en las Américas. Un saludo cordial a quienes están hoy en la sala acompañándonos de manera presencial. Un especial saludo a los representantes de la Comisión Permanente de Canadá ante la OEA, Gillian Guillén y Heidi Sánchez, por estar hoy con nosotros en la reunión. A Claudia Theriot, directora adjunta de Salud de Derechos de la Mujer, Adolescentes y Niños de Asuntos Globales de Canadá, que nos acompaña de manera virtual. Y por supuesto a nuestro director, doctor Jarbas Barbosa, al doctor Fitzgerald, director del Departamento de Sistemas y Servicios de Salud de la OPS, y a la doctora Cerrulla, jefa del Centro Latinoamericano de Perinatología. Muchas gracias también a todos los participantes y colegas que nos acompañan de manera virtual esta mañana en esta reunión tan relevante. El programa de hoy es de 2 horas y media, así que debemos ser muy eficientes en el tiempo que nos han otorgado los organizadores. Antes de empezar, quisiera brevemente compartir con ustedes algunas instrucciones en el manejo de la plataforma de Zoom para que todos estemos en la misma página. En la parte inferior de la pantalla de Zoom encontrarán el menú de funciones. Hoy contaremos con traducción simultánea al español, portugués e inglés. Para acceder al idioma de su preferencia, por favor, ubiquen el icono en forma de globo en el inferior de su pantalla. Allí pueden hacer clic para tener acceso al idioma de su preferencia. Le solicitamos mantener el micrófono en silencio en todo momento, excepto cuando se le invite a hablar, a hacer una intervención o a hacer una pregunta. Por favor, no olvide apagar una vez haya terminado su intervención. Le solicitamos también mantener la cámara encendida durante su presentación o intervención. Puede utilizar la función chat para hacer un comentario o plantear una pregunta. El chat estará monitoreado constantemente. Por favor, hable despacio y claro para que los intérpretes puedan traducir adecuadamente. Mi nombre es Carolina Gómez, hago parte del equipo técnico de la Unidad de Curso de Vida en el Departamento de Sistemas y Servicios de Salud de la OPS y estaré moderando hoy junto con el doctor Rodolfo Gómez, asesor de Salud Sexual y Reproductiva de la OPS, esta reunión. Para dar inicio con la agenda de hoy, quiero invitar al doctor James Fitzgerald, jefe del Departamento de Sistemas y Servicios de Salud de la Organización Panamericana de la Salud, para que abra la reunión con unas palabras de bienvenida. Gracias.
Muchas gracias, Carolina. Realmente quería darles todos muy bienvenida a la OPS.
Warmly welcome all of you to Tahoe. It's Tuesday after a long weekend here in Washington. Special thanks to our permanent representative with the Canada mission at the OAS, Gillian Gillen. We also have Ms. Claudia Theriot, who is the Deputy Director for Health and Rights of Women, Children, and Adolescents. She is joining us online. I'd also like to mention Ambassador of the Permanent Mission, Ambassador of Spain to the OAS, Carmen Monton, who's also here with us this morning, and also to our distinguished representatives from the Human Rights Commission of the OAS and other representatives of the US government present here in the room, the Director of CLAP, Suzani, and all the participants who are here representing countries joining us this morning to have a conversation and to have a discussion on a topic which is extremely important in the current context of international organizations, also health care systems, and it's one of the major pillars to ensure access to health in all countries of the region. This is sexual and reproductive health in the Americas. I'd also like to acknowledge all Tahoe staff in the room and also joining us on Zoom. Last year, Tahoe governing bodies adopted a very important document. It was a report presented to the Council by Canada on the status of access to sexual and reproductive health care services in the Americas. The study was based on a set of norms and mandates the organization has had for many years. It was especially based on a complex situation in the Americas in terms of policies and plans governments have to ensure access to sexual and reproductive health care services, and also the challenges faced by countries and their populations when it comes to access to said services. The report lays out the context and the challenges faced by the population when it comes to accessing these services. Also, it outlines inequalities and barriers that are still in place in the systems themselves that may impede access, be it geographic, financial, social, or administrative barriers. In the report, we stress the need to expand access to reproductive health care, and this is aimed at reducing these inequalities and guarantee human rights to achieve universal access to health care and achieve universal coverage, with a special emphasis on sexual and reproductive health. A number of recommendations were presented and they were welcomed by the member states of the organization. I'll mention a few. First, promote and implement frameworks and policies to ensure the exercise of sexual and reproductive rights without discrimination of any type and with an equity lens to ensure fairness in services. Secondly, to take actions that are needed to expand access, to dismantle persistent barriers that prevent expansion of healthcare services with a gender approach and with the leadership of countries to guarantee access to healthcare services for women, ensuring comprehensive reproductive health care. A major social challenge is community participation. We want to step up community engagement in designing these services to make sure that they're appropriate for the populations and their specific needs at the local level. Also, to address the issue of human resource training, special teams that have the required awareness. They understand the need to have comprehensive approaches to sexual and reproductive health care. All of this means increasing financing for sexual and reproductive health as part of policies and programs, ensuring appropriate and sustainable funding, and especially to ensure the implementation of cost-effective interventions that are already available, but unfortunately are not made available or face serious access barriers in the region. There's also a need for intersectoral work to strengthen healthcare protocols in health, education, and social protection sectors to promote comprehensive policies that will make it possible to have an impact on the determinants of social and reproductive health and address the vulnerabilities of the population to ensure that they can take responsibility for their own reproductive health and concomitant rights. We will be hearing a presentation by Suzanne today. She will speak about the context we presented last year in the document, and she will also provide information about the document and how you can access the document, which is approved by Bajo's Directing Council last year. We will also hear about country experiences, best practices, and also challenges they face. as they strive to ensure this right to reproductive health. As Director of the Health Systems and Services, I wanted to thank you for joining us today for this event, and I would also like to thank the countries that are going to be presenting their situations, especially Brazil, Colombia, Grenada, Honduras, and also the Andean countries, and the network of Afro-Latin, Afro-Caribbean women and the diaspora. We will also be hearing from them a bit later. So once again, I'd like to thank you and now give the floor back to Carolina. Thank you, James. We will now hear from Dr. Jarbas Barbosa. We have his prepared remarks. Please start the video.
É para mim um honor poder dar a bem-vinda a esse importante evento às distinguidas autoridades de saúde e a todos os participantes nessa reunião sobre o acesso a serviços de saúde sexual e reprodutiva nos países da região das Américas. Hoje, no Dia Internacional de Ação por la Saúde das Mulheres, quero destacar alguns elementos que considero claves na defesa da saúde, da vida e da dignidade de todas as mulheres de nossa região, de las madres, hermanas, amigas,
mothers, sisters, friends, colleagues, and especially of those who are in situations of vulnerability and invisibility. On the 30th Pan-American Sanitary Health Conference in September 2022, member states requested that PAHO report on the current status of access to sexual and reproductive health services in the region. The report, which was presented, noted that most countries have improved their service coverage in the field of reproductive health. Coverage is now at 81% in the region, which is higher than the global average of 74%. And yet, those indicators also reflect inequalities across the region and also within countries. Access barriers are greater in populations that are vulnerable. And this means that some groups face worse results when it comes to reproductive health services. Addressing these inequities is essential to achieve universal health, protect human rights, promote gender equality, fight discrimination, and improve the social determinants of health.
Permita-me, por favor, continuar agora em inglês.
If I may, I'd like to switch to
Global interest in women's health is largely focused on maternal health. Maternal mortality remains unacceptably high in the Americas and is not commensurate with the level of development in the region and the resources that have been invested to address this problem. Although antenatal consultations and hospital delivery are available to most women, barriers to equitable access persist, including unequal quality of care and overburdened health personnel. The document we are discussing today reiterates the importance of the promotion and implementation of normative frameworks, policies, and regulations with a primary healthcare approach that will strengthen the capacity and effectiveness of the first level of care in integrated health networks, ensuring services with a comprehensive approach to health, sexuality, and reproduction. It is essential to strengthen intersectoral work between the areas of health, education, and social protection for the implementation of comprehensive policies and programs to intervene on health determinants and to guarantee the effective enjoyment of sexual and reproductive rights for all women. It is also necessary to strengthen political commitment to ensure adequate and sustainable financing for the implementation of cost-effective interventions within health systems. This event will provide a situation analysis of the status of sexual and reproductive health services in the Americas, highlighting existing capacities as well as barriers to access, with measures proposed to improve the situation based on evidence. With sustained and collaborative efforts, we can foster societies in which women can experience motherhood in a safe, positive, and dignified manner. The imperatives of health and human rights are clear. It is time for the global health community to unite around the agenda to ensure women's sexual and reproductive health and rights for all. Thank you.
Bueno, excelentes palabras del doctor Barbosa. Ahora quisiera invitar a Claudia.
Thank you for those excellent and inspiring comments. I would now like to offer the floor to our next speaker, Claudia Terol, Deputy Director of Health and Rights of Women in Adolescence.
Hello, everyone. Good morning. Buenos dias, bon dia, bonjour. It's such an honor to be with you today on this significant occasion as we celebrate the International Day of Action for Women's Health. Today is also Menstrual Hygiene Day, reminding us that the taboos and stigma surrounding menstruation are significant barriers to the health and rights of women and girls around the world. Today, we come together to discuss sexual and reproductive health and rights, a topic fundamental to women's health, their families, and their communities. In the Americas, the challenges and opportunities related to SRHR are diverse, reflecting our rich cultural, social, and economic landscapes. As mentioned last September during PAHO's Directing Council meetings, this information paper is an important milestone as it shares key indicators related to sexual and reproductive health in the region, and therefore gives us an invaluable tool to design and implement evidence-based SRHR programs. Canada will look to this document as a foundational piece of evidence for our SRHR work at home and around the world. Canada appreciates PAHO's initiative in coordinating this high-level meeting for the purpose of building a regional work agenda and identifying areas of cooperation among countries. Supporting SRHR is essential for sustainable development, including attaining global goals, targets, and resolutions linked to gender equality and the empowerment of women and girls in all their diversity. We know that a lack of investment in SRHR contributes directly to increased maternal mortality, adolescent pregnancies, and rates of HIV. Moreover, without the ability to control and manage their sexuality and reproductive choices, women and girls have limited power over other aspects of their lives. On the other hand, there's overwhelming evidence that bodily autonomy and SRHR are critical to achieving gender equality. We know that when women's rights are respected and protected, they face less barrier to education, employment, health, and leadership roles in their societies. This is well documented and indisputable. A comprehensive approach to sexual and reproductive health and rights will always include the rights of all individuals to make decisions about their bodies, free of stigma, discrimination, and coercion. For this reason, in line with Canada's feminist international assistance policy and our 10-year commitment to global health and rights, Global Affairs Canada is committed to supporting access to the full range of sexual and reproductive health services and information. Over the last several years, we've been proud to partner with PAHO on the project Improve Health of Women and Adolescent Girls in Situation of Vulnerability, valued at $15 million. The project empowers women and girls to advocate for their rights while strengthening the resilience of health systems in partnership with health ministries in Bolivia, Colombia, Ecuador, Honduras, Guyana, and Peru. It was also designed and implemented with inputs from the very people it targets, including marginalized communities, such as Indigenous people, migrants, and Afro-descendant population, because Canada prioritizes centering the lived experiences and expertise of local population. And we remain steadfast in our commitment to global health and rights and putting women and girls at the heart of all that we do. And we know that encouraging partnership and networks amplifies our impact and reach in promoting evidence-based SRHR throughout the Americas. In May, in New York, we celebrated 30 years since the International Conference on Population and Development, ICPD. And Canada joined 80 other countries as signatories to a joint regional statement, reiterating our commitment to the 1994 Program of Action. This shows that we have more in common than we sometimes think, and by finding common ground, we are able to move forward together. On a side note, Canada wanted to share our deep appreciation for Honduras and Ambassador Espinosa's leadership in sharing CPD this year. We look forward to many more collaboration with you. Regional meeting like this one today build on an historic momentum by fostering a collaborative environment where we can share insights, experiences, and best practices. We are privileged to have a wide and diverse group of participants today, including policymakers, healthcare providers, and community leaders. Your expertise and perspectives are invaluable, and I'm confident that our collective efforts will lead to meaningful progress. So let's approach to this discussion channeling Ambassador Espinosa's spirit of collaboration. Together, we can pave a way for a healthier, more equitable future for all women and girls in the America. I thank you. Muchas gracias. Obrigada. Yes.
Muchas gracias, Claudia, por tu presentación.
Thank you, Claudia, for that presentation. I would now like to offer the floor to Director of CLAP, who is going to begin with her presentation. Well, good morning, ladies and gentlemen, and thank you very much for joining us. Today is truly a landmark occasion, one of the most important events for all of us who are vigilant in our efforts to support women's health, working in efforts and in unison to save the health of women. As the director has already indicated, Dr. Jarbas, the report that we present, which has the backing of Canada, is a measure that again leads to such important events like this webinar and a document that we're going to share with you. In addition, we're going to discuss with you the opportunity, well, it is an opportunity to share with you the various elements that we consider to be crucial. The first priority is this one. The moment that the report was presented for consideration by the ministers, since then, and of course, we have received full and total support. Countries have shown that they are fully committed to move forward in our efforts for sexual and reproductive rights. 3.7, of course, as we've already discussed, that is linked to all of the Sustainable Development Goals, the SDGs. That 3.1, of course, dealing with maternal mortality. We already have almost 500 people who've joined us on this Zoom event. We have the report, by the way, in English and in Spanish, but we're going to discuss the content in 4 languages. Now, with the new document, we're going to present the content so that you can copy it. Why is this important to disseminate this? Our director has already highlighted one of the key findings contained in the report. Sexual health and reproductive health shows within differences within countries and between various segments and groups of women. So we see here what we call the composite index in health and reproductive and sexual health that includes family as well as covering the LGBT community as well. People think that it focuses mainly on ensuring rights, but to do this, we need to look at the communities of women that most need this. So we're going to look at this on the basis of family planning, because I think this is one of the more crucial aspects. We know that family planning pregnancies provides women with the potential to enjoy the full benefits of maternity. And this will also avoid unwanted pregnancies. This is part of, and it's actually a basic reproductive right. And of all the women in the region, we're about 1 billion in the Americas, more than 100 million women every year seek to exercise this right. When we look at the number of women who don't access these services, we see a total of about 18 million women who don't have their needs satisfied because of the lack of services in the local jurisdiction, maybe lack of commitment by governments. We could also mention all of the barriers, but even more important, we need to understand that among these groups of women, and I'm also going to include adolescents, this is an area of particular interest because of the importance that it has in developing human capital that has been identified by the representative from Canada as well as the director. The sexual and reproductive rights ensure a country's successful development. And here we have the focus that people think that the investments are very costly and that it would require enormous efforts by countries. But the reality is that in addition, but by investing $1.33 per capita every year for providing women, this will provide adequate coverage for women. So this would save countries. It would translate into savings of $3.61. That includes the maternal health, infant health, as well as abortion rights, where they're considered legal. So we believe that it's not just a cost-effective investment, but it's also an investment that allows and encourages the full development of women's potential as well as of their children. Let me also mention that since last year, since we published this review, we emphasize the fact that there's already a very wide set of practices that have significant impact. What do we need to do to create the right environment? Well, we're already starting by holding meetings like this one. That's why it's so crucial, and I appreciate all the authorities who've joined us. We want to continue advocating family planning programs. These need to be a permanent feature of programs. We need to be fully committed with all of the responsibilities that this entails. We need to monitor, we need to supervise government support policies. We need to ensure that this will truly have an impact and function for the benefit of all women. 80% of our women have had their needs addressed, but 20%, the most vulnerable segment, adolescents, Afro-descendants, those who may face challenges in their locations. They may be migrants, or maybe they have less access to information. We need to reach out to these communities. We need to understand that planning has various dimensions and levels. Sometimes the local level lacks essential inputs that includes planning resources. Additionally, something that we've seen very clearly present during the pandemic is that the supply chain needs to have a high level of professional staff. We need to be cautious to ensure that we don't have, such as during the pandemic, where we had 30 million women that were lacking these services for almost 3 years. So we need to increase leadership capacities, management skills. And these programs are important in the family planning program for our healthcare staff. We need to do this also to focus on empowering and training women themselves. We know that Canada and other countries in the region that have prioritized these efforts shown significant reactions and responses. And this is something that we know. Those children, those girls that stay in school longer will wind up getting better paid jobs. And something that goes beyond this, in health, when they will be able to improve their health outcomes. So we believe that these intersectoral efforts are essential. Now, in terms of providing services, we seek, first of all, to ensure that at the community level, you need to strive for integration, not only training people, but you need to have or provide support in their local communities. We also seek to provide proactive services and counseling. I know I'm going to talk about it, and others are going to talk about the need to provide that service even after giving birth. So we need to provide the methods, modern, up-to-date, and effective measures to have a better better planned pregnancy. So within the institutional marketing, the social marketing, we need to work using all of these methods. It's common in countries where young girls will not seek out the implants because many health workers don't know how to use these applications, and they're very modern, up-to-date resources. So we need to work with a basket of methods that can be provided to each person, their best options. And another key issue is that today we have so many ideas, we have so many technologies, innovations, and many of these, again, with the support of the Canadian project that has provided great assistance in Honduras and Peruvian communities with units these modern vehicles and units that will give access to women in their communities. And we cannot lose opportunities, for example, in addressing the needs of women in these units. We need to generate social as well as behavioral pattern changes. Now, we talked about the professional service, but we need to expand that to society at large. And that's why we constantly encourage a discussion of the wide array of communities with different perspectives, different approaches. We know that at PAHO, the strength beneath all of this lies with our partners, working together, as we've already heard from Canada and the words of our director. This is the way we're going to move forward. We know that there are multiple interventions that are necessary through schools, through social media and communications to ensure that we can achieve better exercise of sexual and reproductive rights, which means that we want to prevent unwanted pregnancies among adolescents. And here at PAHO, our director has instructed us to catalyze sexual health and reproductive health, because this will lead to better levels of development, and it will also reduce maternal mortality rates. That is something that we believe is the effective way to achieve it. So there are strategic partnerships and networks, and I see that evident with all of our colleagues present here. And now I know that we have present on the Zoom platform, we have people from the ministries, directors of services, all of our audience who are health professionals listening to us. And that's great, but we also have other spaces where we can continue to strengthen these partnerships. Part of our success with this report is that we have listened to different segments and communities in our societies, and we are trying to increase the efficiency of our funding sources. If we don't have adequate funding or investments, we will not move forward doing everything that needs to be done in the sexual and reproductive health arena. That includes fostering a flow and exchange of know-how, experiences, best practices. And let me just point out that something else that we have been working on to quite an extent in the last few years has been to evaluate these programs so that all the decision makers and managers can get a clear idea as to exactly where are we located, what part of the journey do we find ourselves, and what needs to be improved upon. So we need to mobilize resources so that we can enable these exchanges that in turn will be able to provide that South-South and triangular cooperation that includes multilateral organizations and other partners. It's only through these processes that we can successfully move forward. These are the elements, all four. I'm going to leave them up once I finish my presentation. I just want to say that this is a day of action for the support of sexual and reproductive health. And from the office of the Latin American Center for Perinatology and Human Development, we're so happy that we have them, and we are thrilled that we have the participation from so many other stakeholders who've joined us virtually. This is going to be recorded, and on all of the PAHO channels, we will disseminate the document, and we will work with other locations so that we can make this an element that will be crucial in advocating women's rights. Thank you very much. Thank you, Dr. Cerrulla, for that presentation. Now we're going to show a video, and we will have our colleagues get that.
El rol de la
moving.
partera en la comunidad, más que todo, es el apoyo a salvar la vida, madre y niño.
Nosotros hacemos como acompañamiento con sus baños, con vapores.
We accompany their baths with steam, with traditional plants. We accompany the couple, including the spiritual part as well. Nearly 4,000 women each year die due to pregnancy-related complications.
La capacitación a las parteras es muy importante.
Training traditional birth attendants is very important, especially to strengthen knowledge, both in traditional medicine and in Western medicine. Community technology generates a meeting point between Western and traditional medicine. We don't want women who are pregnant in childbirth or after childbirth to die.
En la medicina
With traditional
ancestral,
medicine, it's important to continue that knowledge so that it's not lost, and to make a connection with Western medicine as a complementary support. coordinate with health centers, articulate with health centers, with the doctors, with each health center, with each hospital. We would like to articulate so that we can coordinate what the situation of the pregnant women is. For me, it is satisfying to see that the deliveries I attended, that those children are already professionals. For me, it is a satisfaction and a joy that we can save a life, and most of all, avoid maternal death, because when a mother dies, that power in the home is lost. Because the mother is what gives strength, that takes care of the children and their development.
Quisiera mencionar
I'd also like to mention that the video you just saw was actually developed within the framework of supporting women and children in vulnerable situations. This was, again, a Canadian initiative focused on providing assistance and strength to women's health. I'd now like to offer the floor to Dr. Rodolfo Gomez. Thank you very much, Carolina, this regional advisor for sexual and reproductive health at CLAP. Let me just discuss what we have over the next few minutes. We're going to have a discussion that will address some very important information. The regional experiences that are going to be presented by the various stakeholders. We're going to look at countries and sub-regions that have been successful in advancing on specific critical points, as my predecessors already highlighted. We're going to be looking at the Afro-Latin American and Afro-Caribbean and Diaspora Women's Network. We're going to be addressing the issues from the women's perspective, the key critical points that governments cannot overlook. Then the Minister of Health of Honduras, Dr. Carla Paredes Reyes, is going to discuss the commitment made by her country in the area of family planning. Then Nestor Edwards, Chief of Nursing from Grenada, is going to be discussing some of the paths that the country has committed to move forward on. Then Maria del Carmen Calle Davila, Executive Secretary of the Andean Health Organization, will share with us lessons learned as a result of the implementation of the Andean program on reducing adolescent pregnancy. Then Renata Reis, who is a health coordinator for women at the Ministry of Health in Brazil, will discuss some of the commitments that have been made in the area of gender violence. And then finally, Julian Fernandinho, Subsecretary or Undersecretary of Public Health in Bogota, is going to look at the efforts made by the country, especially in the capital, Bogota, efforts undertaken in improving access to family planning services. These are the links to the documents that were already identified by our director, and we're going to give you an opportunity to download or look at these documents. We have the official document that was published by PAHO and some of the others reports that we are disseminating. I'd like to now introduce our first panelist, Paula Yanez, who heads the Afro-Latin American, Afro-Caribbean, and Diaspora Women's Network. This is a space that is focused on empowering Afro-descendant women, looking at strengthening democratic, equitable, and just societies that are multicultural, that are free from racial discrimination, sexism, that focuses on inclusion and promoting interculturality. Welcome, Paula, to our panel. We would like to, first of all, ask this question. From the perspective of your role as a leader of empowering Afro-descendant communities, what are some of the key issues that you envision What are some of the areas that were overlooked or neglected by the Ministry of Health, and where you would like to see more efforts aimed at increasing access to service? And maybe explain exactly why this needs to be done. Well, good morning, and thank you very much for giving me this space and opportunity to discuss these issues. I would like to mention just how important it is to participate in this space, which in the past has been seen as very rare, looking especially with regards to Afro-descendant women's organizations. I would just like to mention that it would be a mistake to not recognize the significant progress we've seen over the last few years. If we look just in retrospect, 15 years ago, 10 years ago, there was very little understanding about addressing the gender issues from a racial perspective, especially looking at it from the perspective of sexual and reproductive rights. We are a part of the universal needs, and of course, sometimes people did not focus on specific needs of individual communities. That has changed. Now we have, in this document, evidence of significant advances in eliminating cultural biases. So sexual rights, and as well as lessons learned from ideological and as well as cultural perspectives, looking at the family and the various other institutions involved. All of that is important to discuss because we have seen an absence in the healthcare systems in the past, which was the stereotyping the bodies of Black women and how sexualizing the bodies of Black women has a very negative impact the time that they receive sexual and reproductive services. And it places young girls in a high level of vulnerability, exposing them to the potential for sexual and gender violence. There'll be the stereotype that these groups have, they're more sexually precocious at a younger age. All of that impacts on the racial profiling and stereotyping has been very negative in terms of receiving health services. So how can we work with health workers? How can we sensitize health workers so that women will be receiving more respectful and treated with dignity and avoiding racism? And with the Afro-descendant community, again, we've seen we need to increase their visibility through the census data and statistics. The census data is a key component in making our community visible to come up with potential solutions. When we're thinking about crafting new healthcare policies, what are those areas that could be of universal access? We need to talk more about some of the changes. We have to rectify healthcare administration practices. How can we address the individual needs and characteristics that the Afro-descendant women face in the realm of healthcare? And how can we dispel these stereotypes?
Thank you very much, Paola. I have one more question. Based on your network's experience in the region, what would you say are best practices when it comes to participation? And what examples could you give us of things you would not like to see happen again in the region as far as curtailed participation? What would you not want to see when it comes to women's engagement in public policy? I think we're at a juncture where there's significant backsliding in the region. There's backsliding in terms of progress that took decades to achieve. So having this document presented at this time is the result of a great deal of effort have the ministries sit down with organizations and people to discuss it is also something that's taken many years to hear their voices and consider the views of the Afro-descendant populations. So this is what I would say is a best practices, this dialogue with international organizations, with civil society, where all of us can work together, where civil society is not viewed in terms of the source of complaints, but rather as a valid interlocutor. So that, I think, would be a best practice. Then there's also some very good practices when it comes to civil society organizations and other non-state entities. These are practices that are highly replicable and which can be very useful. For example, everything having to do with an interperspective lens, language, linguistic identities, respecting traditions and norms, also how we build different types of indicators for community involvement, how we engage the community to get information about illness, childbirth, and other community practices that are outstanding, that are best practices and would help to expand healthcare coverage and also provide new approaches to meeting the needs of the population. I think that that is something we need to bolster. We need to do more than in the past to avoid backsliding at the country level. There are some countries that have developed training policies for healthcare personnel, to those who deliver services, to prevent any type of racial stigma or stereotyping of Afro-descendant populations. There's been good results there too. The personnel is aware and open and ready to support, and that's important when it comes to sexual and reproductive health in communities and in different areas of the region, so that we can make strides with the agenda, not just for population and development results, but think of the world we really want, a world with social and reproductive, sexual and reproductive health, and without racial discrimination and without violence. So we need to look at sexual and reproductive health not in isolation, but as something that has a lot to do with other areas like gender-based violence and economic issues. Without economic justice, there can be no reproductive justice because these are intertwined. For example, taking into account labor issues and distribution by gender, also how racial issues impact reproductive justice and how economic resources have an impact on decisions that are made, especially when it comes to reproductive and sexual rights. These are all elements that are affected by economic decisions, and therefore we need to be aware of that when we make decisions so that we can take the right actions when it comes to sexual and reproductive health. Thank you, Paola. That was a very thorough answer, and we very much appreciate your commitment. We know that you're about to travel, and we wish you a very good flight. Thank you very much for joining us, and we'd love to have you take questions at the end. I'd like to introduce our second panelist, the Minister of Health of Honduras.
Nuestra segunda panelista, la doctora Carla Paredes
Our second
Reyes,
panelist is Dr. Carla Paredes Reyes, and she is going to be telling us how the country has decided to guarantee access to modern family planning methods in Honduras. Family planning is essential in Latin America and the Caribbean as we strive to address the many socioeconomic and healthcare challenges. Facilitating access to contraceptives, as our director just said, is an important step towards reducing poverty, improving public health, and social development in general, providing for healthier communities that are more prosperous throughout the region. FEM 2030 is a global initiative that includes states, social, international agencies, and the private sector, also academia and activists, including youth, because as there's more autonomy in family planning decisions, there's more protection for sexual and reproductive rights of all persons. Welcome, Minister. Thank you very much for joining us today. And we would like to ask you to tell us about your country's initiative to guarantee access to modern family planning methods. Could you tell us about the governance structure the country has put in place? Welcome, and the floor is yours. Thank you for the opportunity to join you today at this very important event. I'm very pleased and I congratulate all previous speakers. You've had excellent presentations. So first, as a country, we're very proud to have taken the initiative to participate in this initiative, which is Initiative 2030. We truly are grateful for PAHO's support, and especially grateful to Canada for having included us and for having embarked us on this adventure. Our governance structure is very clear. The Secretariat of Health is and will continue to be the leading entity when it comes to healthcare in the country and sexual and reproductive health. We have long-standing experience, and even though our results may not be as extraordinary as we would like, we have been able to achieve good results. We have a sexual and reproductive health program. We have a highly qualified team. The state guarantees inputs for 6 different contraceptive methods. So we are convinced that the way in which we govern and manage programs is in itself a guarantee for transparency and accountability and extraordinary results for the population we serve and the population we are here for. Thank you very much. For benefits of the audience, I'd like to say that Honduras is the first country to sign this commitment, Reliance 2030, which guarantees access to modern contraceptive methods. Minister, I'd like to ask you, what accountability mechanisms have you put in place? Could you please share that information with us? Of course, it's been a number of decades that we've been working on this. Initially, it was family planning. Now it's called sexual and reproductive health, and it covers all family planning methods. The program has policies, it has processes, it has procedures, it uses indicators, there are clearly established flows, and there is accountability. For us, after reviewing our existing structure, we find that with the current structure, with some slight enhancements, especially when it comes to accountability and transparency, and given the support from Canada to further strengthen sexual and reproductive health, we will be able to meet the requirements of our donors and of our country with interventions that are designed to guarantee transparency, timeliness, and proper execution of national and external resources that are made available or invested in the population, and health is no exception. ONADICI, through the Superior Court of Accounts, is an internal body that oversees all state institutions, and CESAL, which is our health ministry, also has internal bodies that are overseen by these external agencies and that are responsible for control. They have shown to be effective thus far to guarantee transparency. So we feel that our program, with all the existing processes, is able to adequately meet requirements in time and form to the satisfaction of our cooperating partners and also fulfill local requirements, not only as far as governance is concerned, but also as far as accountability and results, which is something we are stressing. Thank you very much, Carla. Last question. Do you have your own budget? How does that work? Yes, we do have our own budget. As in the case of vaccines, the country guarantees every lempira invested in family planning. We invest $2.3 million on average for a population of 9 million. The population in reproductive age is at 2.9 million, I think, but the amounts are fully guaranteed. By 2024, we transfer funds to UNFA, which is responsible for international procurement of different contraceptive methods. So up to 2025, it's been guaranteed. For the following year, the money has been earmarked for future procurement. I can fully assure you that until 2025, we have fully guaranteed the required lempiras, which you can translate into dollars. And this is for procurement of family planning methods, which the country pays for with its own funds. We do not rely on grant funding or loans. This has been the practice for years, and I don't expect it to change. Thank you very much, Doctor. It's been a pleasure to hear you. I'd love to continue this conversation, but we have to move on to the next participant. Thank you for joining us, Minister. It's been an honor to have you with us today.
Now we are inviting to Nestor Edwards. Our next panelist will be, speaking from Grenada, understanding clearly that 1 in every 3 women in Grenada has been experienced intimate partner violence in their lifetime. The first comprehensive national survey on gender-based violence in Grenada revealed that 29% of all women experience at least one form of violence, in line with the global average that 1 in 3 women will experience physical or sexual violence during their lifetime. Welcome, Nestor, to our panel. And we want to know, why would you define this response to violence against women policy as a good practice for sexual and reproductive health policies in Grenada? Welcome.
Thank you very much, Rodolfo. Thank you. It's a pleasure for me to be here this morning in this very important conversation on violence against women, sexual and reproductive health. Violence against women and girls is a major public health issue and a violation of women's rights. Violence negatively affects the physical, the mental, the sexual and reproductive health of women and girls, and can increase the risk significantly to unwanted pregnancies, unsafe abortions, HIV, and other STIs, and even the loss of lives. So we all know that violence is preventable, and the health sector, particularly Ministry of Health, has been playing an integral role in providing comprehensive healthcare services to women and girls subject to violence. We've had training done to healthcare providers, nurses, doctors, as well as other non-health sector personnel in relation to gender-based violence. How do you recognize a woman who have been subject to gender-based violence without she disclosing that to you? We've done training in the long-acting reversible contraceptives. A number of our midwives were trained. They first completed an online training, and then they went on into the actual hands-on practice. 95% of live births, 90% of our normal deliveries are done by midwives. So it is important, that our midwives are equipped with the knowledge and skills, that they need to provide comprehensive sexual and reproductive health. We've done training on the medical legal aspects as it relates to gender-based violence. We've had 3 of our doctors who would have traveled to Guyana and did a training in the clinical management of rape. And upon return, were able to train a large number of persons in Grenada, including healthcare professionals, persons within the police force, and other sectors, other stakeholders. It is important to note that we do have the political commitment where violence is concerned. In fact, in 2021, we've had our cabinet approving a national standard operating procedures, for service providers, and that include the health sector, the police, the justice sector, and the social services sector. We've also engaged in a series of refresher training, and what is important for us is the sensitization of the public on the dangers associated with violence. We have done tremendous amount of work in terms of changing the social norms that go along with gender-based violence. So I think that this discussion is quite relevant, it's timely. We do face challenges from time to time as it relates to resources, particularly as it relates to SRH services, having adequate numbers of the human resources, as to provide the services, but we have made tremendous progress. We do have and approve, as I mentioned, standard operating procedures to guide the delivery of services. Thank you.
Thank you very much, Nestor. My next question is related to what are the reasons that encouraged you to design this policy?
Okay. First of all, what we notice is that the delivery of our services as it relates to SRH and gender-based violence has been sort of fragmented and uncoordinated. The police was receiving some of the data, they have some of them going straight to the healthcare services, and then we have the Ministry of Social Development or Social Services that were also providing the services. We also have the Child Protection Authority. We also noticed that there was lack of clarity in the roles of the various stakeholders. Who should do what? Who should report to whom? So we wanted to improve the quality and the consistency of the services provided to survivors of gender-based violence and other forms of violence, and standardize the response to violence against women and girls, acknowledging that, it takes on greater significance, during emergency situations, when, violence tends to increase. We also wanted to improve the partnership and coordination between the essential sectors. And here I speak of the health sector, the police, social services, and the justice sector. For the health sector, we also noticed that there was a certain reluctance among healthcare professionals in providing evidence in courts. And so we thought that if we increase the awareness of the importance, of providing medical, legal, well-documented evidence in court, they would be better prepared and understand the importance of it. So as I mentioned earlier, for health, we took on the medical legal training, as a priority, and to better prepare, our doctors, nurses, those who work within the accident and emergency department where the survivors will go for care, to respond adequately to gender-based violence. These were the reasons that led to the development of the standard operating procedures, which gave clear directives in a step-by-step manner what step to follow. It gave a clear pathway, in terms of referrals, So yes, it's very important for coordination, and we are seeing better coordination in terms of the services that we provide to survivors of gender-based violence. Thank you.
That guides to my last question, Nestor. That is, what is the most important elements that you consider to design the policy? What are the most important elements that you can highlight?
We took into consideration.
Coordination, you said one,
Yes, we took into consideration a multi-sectoral approach, and we sought to get support and buy-in from all stakeholders. So we adopted a consultative process. We wanted the SOPs to serve as a framework for accountability so that we can hold each of the service sector accountable for the quality of services that were delivered to survivors of gender-based violence. We also considered the respect for human rights, right? We took a survivor-centered approach. In fact, recently, in collaboration with the Grenada Planned Parenthood Association, there was a launch of a one-stop center where survivors can receive all the necessary services under one roof. That was recently launched. And that is new, and it's a progress for us. It's a huge success for us. We're still grappling somewhat with having the adequate resources to have it fully operational, but that's a huge success for us. Also, we took into consideration the building of capacity among service providers, they need to have adequate resources, as mentioned earlier, and not only the rape kits, but the emergency contraceptive, the post exposure prophylaxis treatment, and all those things we considered. And in case of children, we took into consideration the best interests of the child, the safety of the child. Thank you, Rudolph.
Thank you so much, Nestor. Your answer just were so clear. Thank you very much. And I want to invite our next speaker, nuestra próxima colega.
Our next colleague, and we're switching languages again. We're going back to Spanish. It's Dr. Maria del Carmen Calles. She's the Executive Secretary of the Andean Health Organization. And just to give you some background, and let me say that ORASCONU is a sub-regional organization aimed at coordinating and supporting the efforts of member countries individually and collectively to improve the health of their populations. It coordinates and promotes actions to improve the health status of member countries, giving priority to cooperation mechanisms that promote the developed sub-regional systems and methodologies. It also coordinates other international, regional, and international bodies which collaborate with this objective. Dr. Maria del Carmen Calle, thank you for joining us. We're going to ask you to tell us about your experience with the implementation of the Andean Plan for the reduction and prevention of unwanted pregnancies during adolescence. Could you please tell us what makes the Andean Plan different? What sets it apart? The plan was completed in 2022. Please go ahead.
Well, first of all, I'd like to thank you for allowing me the opportunity to share some ideas with you. And I know Rodolfo has already mentioned that this Andean organization is a regional integration organization, and our maximum level authorities are the ministers of health of Bolivia, Chile, Colombia, Ecuador, and Venezuela. So we're talking about 170 million people that live in the 6 countries together. In 2007, and this was as a result of the decision made by the ministers who hand down the resolutions, they signed them. This talked about or was involved in one of the most important areas relating to adolescent pregnancies. And on the basis of this decision, a plan was formulated, followed by a second plan. And now we have the most recent plan, the one you've asked about, which is the Andean plan for the reduction and prevention of teenage pregnancies. And on a parallel path, in 2012, the Andean policy for sexual and reproductive health of adolescents was formally implemented, especially focused on adolescent pregnancy, and this has been updated in 2022. What is the key characteristic of this initiative? Well, the main characteristic is that this is aimed at creating greater visibility of adolescent pregnancy, and it highlights it not just as a public health challenge, it's also a human rights challenge, it's a development challenge, it's a challenge relating with gender violence, inequality. It is a challenge completely linked to a country's development. That's the reason why we think that it's crucial that we make this visible, give it visibility, and place it in a priority agenda. So we also look at the reduction of unwanted and adolescent pregnancies. We're looking at the importance of teenage pregnancy, particularly in the range from 10 to 14 years of age, and how it's important to prevent a second pregnancy. Similarly, and I don't want to be redundant, but we're also looking at specific measures aimed at the population of teenagers from 10 to 14 years of age. As you know, that levels of development are very different if we compare early adolescence and look at later adolescent stages. So this has been developed and agreed upon by the representatives of the ministries of health who have this specific task. And that's how we look at this. All of our policies, projects, interventions are developed on the basis of consensus reached by the representatives of the 6 nations. So this committee on adolescent pregnancy is one of the key committees because of their background, their technical skills and knowledge of the members. Also, everything that deals with the involvement and participation of teenagers, we have operationalized their involvement and participation through the various forums. We've had forums in coordination with not just Central America, Dominican Republic. We've included other regions like Central America, where adolescents have provided their inputs, their ideas, and these inputs have been shared with the ministries of health, not just from the Andean region, but from the other regions we were talking about. I think these are the key characteristics that make this initiative stand out. Thank you for your clear comments. Now, my next question is, how would you define this plan, this regional strategy, as a best practice in terms of policies to reproductive and sexual health? And why would you consider this? Well, best practices are the ones, of course, that create or generate results. That's how we would summarize it. We realize that we have contributed, countries, of course, that have made the most efforts. And again, this boils down to our organization made up of 6 ministries. And what we have shown is that we have effectively reduced the levels of teenage pregnancies between the ages of 10 and 15. If we compare the current situation to the past, we've seen the greatest level of teenage pregnancies reduced in Chile, but we've seen a reduction overall in all 6 countries. The Andean plan is really an umbrella of plans implemented in our countries, and ultimately by opening and also strengthening this agenda of teenage reproductive and sexual health and rights, this has unleashed the creation of policies, programs, and strategies at the national level. So it's again crucial. We need to repeat that our maximum level authorities are the ministers of health in 6 countries. And this is all achieved by consensus. The 6 member states discuss each issue. Each country, of course, is unique, it's different, and they consider what's best for them individually. But overall, we believe that by working together, we're stronger. United, we are stronger, and we move a lot further along. And we believe that teenage health and reproductive health is a key priority for the region. Thank you, Mari Carmen. My last question. Speaking frankly, what are some of the key obstacles that you faced in the implementation of the regional plan? I think the main obstacle, and I think this has been faced by all the regional plans, the pandemic. The pandemic shut off so many services. We've seen a lapse and a lagging of recovery of services. To prevent pregnancies, we need to provide quality education from the early years. We need to have services that can provide adequate contraception resources, and we have to continuously support our teenagers. Unfortunately, the pandemic was a major setback when it came to this. The other issue, in a lot of countries, we had a lack of contraceptives, and we saw a reduction in countries where, in pregnancies in countries that had more contraceptives available, more long-term supplies of resources. Of course, we know that the longer-term contraceptives work best. And one other concern has to do with, we need to include the males in all of this. When we review and look at the parents, the fathers of these children, of women from 10 to 14, teenagers, 10 to 14 years of age, we are surprised that a significant number of these fathers are also young people. It's not like in the past where the differences were incredible. Now, we need to work more with the teenage fathers. We know that the issue of male rights is always looked at, but we need to see how males can also be involved within the healthcare services realm. And then another major obstacle that we face has to do with lack of adequate funding. In Peru, we say that without that budget, then we have no rights. And without the funding, clearly defined and well-targeted funding that is adequate, without that, it will be very hard to address all of the objectives envisioned in the plan. So funding, and currently, during the post-pandemic, of course, during the pandemic, we had most resources diverted to address the pandemic. Of course, it was a question of survival, but countries are gradually getting a better awareness about the significance of providing comprehensive services to our adolescents and preventive measures is something that goes hand in hand with effective development policies. Thank you. Your clear concepts have helped us to understand some of the strengths and how we need to rethink sometimes some of our strategies. Thank you very much for joining us and for giving us, and we know that you're in a different time zone, but you actually are it was very, very dynamic. Thank you. Now I would like to invite our next panelist, Renata de Souza Reis. Dr. Reis is a coordinator.
Muito bem-vinda, Renata, e vamos fazer uma troca de língua. Renata vai falar em português. La próxima presentación va a ser en portugués. Si quieren,
Next presentation will be in Portuguese. If you wish to switch, we're going to have this presentation given in Portuguese. Over the next 9 minutes, it will be given in Portuguese. Renata?
You're going to be speaking about the national policy to reduce teenage pregnancy and also focused on violence against women. So I would like to know what the reasons were that moved you to design this program to address violence against women. Please take the floor, and you're welcome.
Olá, meus cumprimentos a todos os participantes
Hello, everyone. I greet all of the participants of this very important meeting. It's a great pleasure for me to be here.
Bem, essa política é política nacional de prevenção
Our national policy
por acidentes e violências
to prevent mortality in women owing to violence against women. This arose as a response to the health sector and women's movement perception that these deaths
no ranking geral de mortalidade aqui no Brasil.
Rank number 3 as cause of death of women. And so this calls for greater integration online and network to bring together all the different healthcare services made available. There was a need for us to bring together all of these healthcare services also with the judiciary and social services. So the enactment of this policy, this took place in 2001, in which this policy was launched, and it reflects the Brazilian society's understanding that violence that takes place within the home or within the family should not remain behind closed doors within the family, within the home, because it is a public health and public safety or security issue as well. Now, the World Health Assembly of 1996, for the first time, granted a priority status to this topic in international fora and debates, and our policy predated that, going back to 2012.
E logo na sequência, a gente também tem a instituição de uma outra política, que é a Política Nacional
another policy, the national policy of a comprehensive health services for women was launched, and that reasserts the importance of incorporating the gender focus to understand this phenomenon and also to best fashion the tailored services for women. Thank you very much. The second question, Renata, is what have been the main stumbling blocks for the implementation of this very worthwhile policy?
Talvez o nosso principal obstáculo seja
Perhaps
o
the
mesmo
main obstacle is the same one that all other countries face, which is chauvinism that's deeply rooted, and that
particular de avanço, né, numa velocidade muito
makes it very important for us to step up the speed with which we're addressing this issue. Sometimes we're just not keeping up the pace of progress, and so in prior governments, there was a breakdown and a backsliding of many policies that had come together by dint of a great effort over time. So we started to resume that process of building up these services. I would also like to underscore that other obstacles relate to what needs to be done to prevent violence and also to offer
seja na sua
care
fase
to
aguda, por
victims.
exemplo, na violência
In
sexual.
acute services,
Protocolos
sexual
ofertas
violence, for
de
example,
recepção
we
de
do have a
emergência, de
protocol
profilaxia para
for
hepatite B e para HIV,
emergency
mas também existem aquelas que
day
ocorrem cronicamente,
after
ou mesmo aquelas que ocasionam
contraceptives.
consequências que demandam, por exemplo, ações de reabilitação. Então,
Then you also have
qualificar
those
a assistência
acts of violence that
propriamente dita
call for
é desafio
rehabilitation
ainda que a gente
services
concorde
after the
nisso.
fact. And so this is something we
E
also are
um outro
careful to
ponto que eu
provide.
gostaria de
Now, something
salientar
else
é
that
que
I
aqui
would
no
like to
Brasil
stress is that in
as
Brazil,
violências elas são agravos de
violence
notificação compulsória. Isso significa que a gente transforma o
has to
fenômeno em
be
evento de
reported.
saúde
It's
pública para
mandatory to
serem
report it to trigger the public health
compreendidos e
service.
vigiados do ponto de vista da vigilância, certo?
And so we have
Então,
to
desafio
be
grande é
watchful.
incorporar no
And so it's a
cotidiano
big
dos
challenge
serviços
for
de
us to work this
profissionais de
into the daily
saúde
activities of the
que a
healthcare workers,
notificação
that
é uma
when
dimensão
there
do
is
cuidado.
a notification
Isso
that someone
contribui de
has
forma
been victim of
significativa
this,
para
that
que
it
o
has to
lugar
kick
de
into action. That's very
formulação e de
important
gestão
because
das políticas
when
públicas, o
public
fenômeno seja
policies
melhor
are
visto e melhor
established, it's very important
compreendido.
that this phenomenon be better
Então,
understood and
para dar exemplo e ficar
that
mais
light be shed
claro,
on it, that it
na
be
ficha
made
de
more
notificação
visible.
existem
Now,
os
in
campos
the
de
report
orientação
file,
sexual
there
e
are
identidade de
fields
gênero.
to fill out for a gender identity.
Contudo, é alto o percentual de
And there
incompletude no
is a
preenchimento
high
desses
percentage
campos.
of
Isso
these
contribui para a
fields that are not filled
subnotificação
out. And
e
that
para a
means there's
invisibilidade
under
institucional do
reporting, and
fenômeno.
that leads to an
Então,
institutional
avançar nessa
uh,
sensibilização de profissionais em
the fact that
serviços
this
de
problem is
saúde
rendered
da
invisible
importância da notificação
in a large
na suspeita ou
measure.
na
And so it's very
confirmação
important
de
that there
violência
be
e que essa notificação seja
reports
de fato
issued,
completa
notification
para que a
actually
gente
be
enxergue cada
complete,
vez
filled out,
melhor como esse fenômeno ocorre na
for
sociedade.
us to have a better
É
understanding of
fundamental para que a gente
the
avance
occurrence
na
of this
superação.
phenomenon. And that's the only way that we're going to ever be able
Muchísimo
to
obrigado.
overcome
Y
it.
a
So
última
thank you very
pregunta
much. The
final
last
sería,
question.
a pesar de las dificultades,
Despite
a pesar de los obstáculos,
the obstacles, the stumbling
como é que você
blocks,
definiria que
difficulties,
essa política é uma boa prática dentro das políticas
how would you
públicas
say that this
de
is a
acesso
good
à
practice
saúde e
within
sexual reproductiva na região?
access to public
O
health
Brasil tem
services
trabalhado,
and sexual and reproductive health? Now, as
como
I
eu já tinha dito, nessa
said,
mensuração de dados em relação à
we have
violência de
been
gênero, né?
working on measuring
Apesar dos
data
desafios, a gente tem
regarding
avançado na
gender-based violence. And the
notificação.
fact is that we have made some progress
Existe
on the
sistema
reporting
de
of
informação de
events. And so
agravos de
there is
notificação e é um instrumento fundamental.
system for
E
notifying when these
esse sistema e
events
esses
happen,
dados
for reporting,
compilados
and
nos
all of
ajudam
this data
a
that we
qualificar e
compile
identificar
makes
o
it possible
perfil
for
das
us
vítimas,
to
quais são as
identify
regiões do
the
país mais
profile of
afetadas e
victims,
outros
what are the regions of the
fatores. A gente
countries where
consegue
this happens the
direcionar
most,
esforços mais
so that
assertivos a
we
partir
can
desses dados,
earmark
né?
our efforts to those most
Para
needy
exemplificar com
areas,
números, entre 2011 e
and so that we
2018,
can
houve um acréscimo
assign numbers.
substancial no
Now,
número
there
de
was
municípios notificantes de violências
a
no sistema
substantial
e acima
rise in
desse
the number of
sistema.
cities for which there
Então, a gente
was
aumentou
greater
de
reporting of these
38%
incidents
dos
in some cities.
municípios em
So
2011
38% in
para
2011 of the cities to
78,7% dos municípios
78.7%
notificando
of the
alguma
cities have
violência em
reported acts of
2018.
violence,
Essa proporção
gender-based violence in
esse número
2018.
é a
So this
proporção de
number
municípios que
represents a
realizaram ao
proportion
menos
of
uma
cities
notificação
that
de
issued at
violência
least one
interpessoal ou autoprovocada naqueles anos,
interpersonal
né? E aí, de novo,
domestic
reforçando que quando se
violence
estuda e se compila
case.
esses dados lá no
And now when we
sistema, a
compile
gente
all of this
consegue
data
ter
in
essa
our system,
distribuição pelo
we get an
tipo de
understanding of
violência,
what the
quem
distribution
foi o
is,
autor da
broken down
violência,
by the
qual foi
type
o
of violence,
local
what gave rise
de
to it,
ocorrência, o
where it
recorte de raça,
happened,
cor,
where it was reported,
gênero e
also
orientação
gender,
sexual.
sexual
E aqui no
orientation,
Brasil existe plano de ações
race, skin
estratégicas
color, all
para o
of that is
enfrentamento de doenças
included.
crônicas e
And then we come
agravos
up
não
with strategies to
transmissíveis, válido até
address
2030,
this.
que além das doenças crônicas também estão
But also for
incluídos as
chronic
violências,
diseases,
os
non-communicable
acidentes,
chronic
e ele é
diseases,
uma
and
diretriz para a
which
prevenção
we
desses fatores de risco
also
relacionados a esses eventos e para a promoção da saúde da
report on these
população,
events, all in an effort
com o
to
objetivo
prevent
de reduzir
or
as
to enhance the health
iniquidades e as
of the
desigualdades em
population
saúde,
and
né?
to bring
No
down
escopo do plano estão a
inequities in
criação e
healthcare. And within the
fortalecimento de
scope of the
políticas
plan,
e programas
we are
intersetoriais, ou
strengthening
seja,
the
que vão além
intersectoral
do setor de
plans and
saúde
programs. So
propriamente
beyond
dito,
the healthcare
a produção de
program
informações
per se,
direcionadas à tomada de
we
decisão
produce information
baseadas
that
em
help in
evidências e
decision
o
making,
controle
always based on
social, né?
evidence,
O
and
acompanhamento
also
social é dos pilares do
social
nosso
oversight,
sistema
which
único
is one
de
of the
saúde.
pillars of our single
A
healthcare
inovação na
system,
gestão, na
and
pesquisa e nos
also
próprios serviços de
enhancing
saúde também.
research and the provision of healthcare services. Thank you very much.
E a clareza que você sempre tem.
And I thank you for the clarity of your contribution. Thank you.
Quiero presentarles, volvemos a cambiar de idioma, va a ser en español. a nuestro último panelista de la mesa.
And we're going to have our final panelist, Julián Alfredo Fernández Niño, Undersecretary of Public Health of the Secretariat of the District of Bogota. Thank you very much for joining us. We know that the fertility levels of the teenagers in Colombia are very high, and we know that this is a vicious circle and continuously maintaining the levels of poverty. We know that there's been a focus, as Maria Carmen already mentioned, to try to break these patterns, to reduce the levels of teenage pregnancy. And this is as a result of sustained policies to try to improve these indicators that translates into better health conditions for teenagers, both girls, boys, and our community at large. So I'd like to ask you, what were some of the reasons that encouraged Bogota to develop these policies? Well, good morning, and thank you very much, Rodolfo. I'd like to thank all of our participants for allowing me to join you in this space. Bogota has historically had good public health indicators, including sexual and reproductive health, compared to other parts, other regions in Colombia. However, in the case of the specific fertility levels between the years 2010 to 2014, we noticed a flattening out of the fertility levels, especially during the ages of 10 to 14. It had flatlined 1.5 for every 1,000 girls, 10 to 14. Then we saw a drop from 15 to 19, but the main concern was that stagnant segment, 10 to 14. So the Secretariat of Education came up with various reports to show the results of early pregnancies during school age. When you see that stagnation in any problem, it means that you cannot continue to do the same thing over and over again. So at that moment, the city held public discussions, policy discussions about the need to change the approaches being implemented to strengthen intersectoral efforts, in particular, to break through that stagnation and move forward. Now, today, we can state that the strategy has been effective, and as you've noticed, we have seen patterns. We've seen a sustained drop, and now we've seen a new drop to 0.6 for those between the ages of 10 and 14. That's why we have maintained the policies, regardless of whatever change in administration we see at the executive level. Thank you. What are some of the key characteristics? What were the characteristics that stood out in this policy? Well, as I mentioned, in 2015, we saw the first efforts about the need to develop a new strategy. These strategies vis-a-vis teenage pregnancies. So we changed the way we viewed the problem, a problem that had been seen in the past as a health-related issue. Now we also looked at it from a social dimension as well. We know for example, we know that this has an impact on poverty, has an impact on educational development, social development. So that was the first change in our approach. But so we wanted to take it out of the health realm, and we wanted to expand and look at it from a multi-sector approach. That's when we really began to see a change in the discussion. Another thing that happened with these people that were the pioneers behind this change of model is that there would be a follow-up all the way up to the age of 24. So this is where the lifetime projects are consolidated. So we wanted to emphasize health, sexual and reproductive health, not just among adolescents, but people all the way up to the age of 24. And another key characteristic was bringing together, and I know it's already been mentioned by other countries, involve the males, not just address female teenage early pregnancies, but also male, their involvement, early teenage fatherhood as well. And then the other issue is that we turned the approach around. We had a vertical educational process. We would say, here's the educational materials, you have to listen. Now we've turned it around where the objective was to, first of all, recognize the sexual and reproductive rights by promoting development of critical thinking skills to lead to better decision-making. So the health leadership, and of course, with the participation of the other sectors, developed this very innovative, and it turned out successful approach. Thank you. And the final question, Julian, what is the governance overall plan or strategy? And is there an accountability component included? Well, first of all, we saw two levels of intersectoral interventions. We had strategic level development areas. We had the operational component that would translate the ideas, the concepts into actions. In order to ensure that intersectoral involvement, there's a series of tasks that need to be distributed, ensuring, for example, promoting women's autonomy and reproductive rights and health. Then education ministry focused on access to better information. The cultural ministry provides other options. And the Secretary of Health provided, for example, contraceptive tools and resources that articulates also the communications aspects. But in order for there to be effective governance, it's not just a question of distributing tasks amongst the ministries. You need to also develop a common narrative. And that common narrative, which was signed on by the Council of Government and that had been ratified by in the development plans that are formally approved by each incoming administration. And by creating a governing board, I'm not sure what they call it in other countries, it's a governing board where the members or city councilmen in local jurisdictions are following up on the fulfillment and completion of many of these targets. And just let me also highlight that this format has been so successful that during the pandemic, where other countries saw disruption of services, we were able to adapt and continue to provide the services required. Thank you very much, Julian. And with that, we have concluded our panel discussion, a very enriching discussion where we saw a significant level of involvement by many of the stakeholders, and we want to thank you all for generously sharing your experiences and time. Carolina will now coordinate the Q&A discussion. I'd like to invite those of you who are here in person, if you have any questions, just raise your hand, or you can turn on your mic.
We just have a few minutes for questions for the panel. After that, we can take questions from the more than 500 people who have joined us online. We have the ambassador of Spain with a question. It's not really a question. I just wanted to share some additional information, if I may. First of all, let me just say thank you to the Pan American Health Organization for having organized this seminar on sexual and reproductive health. I'd also like to thank Canada for its leadership and for having promoted the agenda of reproductive and sexual health and rights in the Americas. As you know, Spain supports this agenda, which is why we are here with you, joining you today, especially Jillian and Haiti. Spain has an agenda which includes sexual and reproductive health for women. As you know, we are also taking the lead when it comes to the elimination of cervical cancer. Spain has endorsed the WHO target of 2030 for the elimination of cervical cancer and is taking steps to achieve this eradication jointly with Bajo. The figures are quite alarming. It's a disease that is fatal for women and girls. Every 2 minutes, a woman dies of this disease globally, and 85% of these women are in low-income and middle-income countries. And we must also realize that it is a preventable disease, if that can be considered good news. In Cartagena de Indias, which is where the Spanish Cooperation Agency has been working with the government of Colombia, especially with Bajo, we inaugurated the first World Forum for the elimination of cervical cancer. And we made a public commitment to invest 10 million euros over the next 3 years in the fight against cervical cancer around the world, not only using different approaches, but also promoting the use of the HPV vaccine. That's what I wanted to share. I'm sorry for having taken all this time, but I thought it was important to mention this in the context of sexual and reproductive health services. Thank you. We have another question over here.
Sí. Okay, muchas gracias.
Thank you very
Yo soy
much.
Sara Paiva de
I'm Sara
Brasil.
Paiva of Brazil.
Me gustaría hacer una pregunta para
I
doctora
have a
Carla
question for
Paredes
Dr.
Reyes,
Carla
secretaria
Paredes
de
Reyes,
Estado
Secretary
del
of
Despacho de Salud de Honduras.
Health of Honduras.
Primero quisiera
First of
felicitar a
all,
la
let me
señora Ministra de
congratulate
Salud de
you,
Honduras por
Madam
adoptar
Minister,
el
for the
protocolo de
adoption
apoyo
of the
a víctimas de
protocol to
violencia
support
sexual.
victims of
Me
sexual
gustaría saber
violence.
cuáles fueron los
I would
avances
like to
y
know
desafíos
what were
en
the
la implementación
strides
del
and
protocolo,
challenges
especialmente
you
lo
faced
que
in
se refiere a la
implementing the protocol,
capacitación
especially as
de los
relates to the
profesionales de salud.
training of healthcare professionals.
Gracias. Carla, por
Thank
favor.
you, Carla.
No sé si la ministra estará todavía conectada.
I'm not
porque tenía
sure
que
whether the
viajar
minister
a
is still
Honduras.
with us. She was traveling
Posiblemente esté
in her
parte de
country,
su equipo que pueda
but maybe there's someone from her team who can answer the question.
De todas maneras, la práctica que presentó Honduras fue el acceso a la planificación
In the
familiar.
event, Honduras spoke about
Firma del convenio
access to
2030.
family planning and
Pasamos entonces, Rodolfo, a
signing
una pregunta
on
del
to
chat
the Initiative 2030.
para el viceministro
We
de
have a
Colombia.
question in the chat for the Vice
¿Tú la
Minister of
puedes leer,
Colombia.
por favor?
Could you please read it?
No tengo la pregunta, Susan, si la pudieras hacer
I
vos
can't see
directamente.
the question. Suzanne, could you read it?
Lo siento a todos que me escuchan
I'm
con esa
sorry
voz
because
engripada.
of my voice. I have a cold, but I'll go ahead. So the question is, one of the key issues is having a more intersectoral approach. I mentioned this as one of the key recommendations in the document. Guatemala has started to work on this, but the question from Guatemala is, what have other countries done? How have they done this? So I'd like to ask panel members, maybe Renata Reyes, Dr. Renata Reyes, or the Colombian representative are willing to answer this question.
Renata, Julian.
Renata or Julian? Does either one of you want to answer this question?
Desculpa, aqui o áudio para mim cortou.
I'm sorry, I didn't hear because my audio was cut. I'm going to ask you in Portuguese. How is it possible to improve the intersectoral work in terms of family planning? This is a question from Guatemala.
Vencendo as primeiras barreiras.
Where they cross the first barriers in terms of having the methods.
A questão da intersectorialidade.
How would the intersectoral work, how has it been done? How has Brazil dealt with this?
Eu acho que o que a gente pode contribuir,
what we can say, more recently, we've had reference centers in 5 states. We want to broaden this with in a partnership of the Population Center of the UN, and they have been multipliers for insertion of intrauterine devices and implants as well. These reference centers are in strategic territories. Therefore, the sectors within those territories are the ones who participate in order to guarantee these services to all women. In terms of the central government, we managed to bring in other professionals in the health system that have been capacitated to introduce the IDU or IUD better, and thus guarantee those rights. I hope my answer helped in terms of the question that was asked.
Doutora Renata, eu sou Sara Paiva do Brasil também.
I'm Sara Paiva from Brazil as well. I work at the National Committee of Sexual Violence, FREBASGO, and I want to congratulate you on your contribution. One of our greatest difficulties is the time it takes to search or look for help. Sometimes we see women and girls who have been pregnant over 12 weeks. So, and this creates difficulties in terms of legal abortion. In Brazil, the situation is worse for women who look for help from 20 weeks on of pregnancy, and our legal system does not allow for such abortions. I would like to know how you see this and how the situation presents itself in the Brazilian code. Thank you. Thank you for your kind words and for the question. And one of my answers I mentioned
para que esse atendimento
I
ocorra em tempo
mentioned
oportuno. Então,
that
avançar nesse diálogo, na
timely
qualificação das equipes
seeing these
dessas
women in a
áreas
timely
especializadas,
fashion
o
is one of
reconhecimento
the
da
great
violência de maneira
challenges.
adequada é fundamental. A gente já tem
Such
desenhado
violence
novas
has to be
estratégias dentro do
acknowledged
Ministério da
in the
Saúde
first place, and
para investir
within the
nessa
Ministry of
qualificação das
Health,
equipes, nesse
we
reconhecimento.
have been
Especificamente sobre a introdução
preparing
da
to
gestação em idades sexuais
qualify
mais avançadas, é importante
people who
dizer
work
que
in
o
the
governo
area in
federal
terms of pregnancies
suspendeu a
20
norma do Conselho
weeks
Federal de
and
Medicina que estava não
over.
só impedindo a
This,
prática,
the norm has been put on
impondo
hold
sanções a profissionais que mantinham a prática
and
do aborto
have been
legal nessas idades
informing
gestacionais.
professionals
Daqui
who
a gente segue com o
practice
desafio
abortion
de
within the
construir
legal frame.
estratégias de debate com a
We have
sociedade,
this
deslocando a pauta do campo moral ou religioso e localizando a pauta
challenge
onde ela deve
to
estar, que é
discuss
no campo técnico
this
e científico,
situation with
respaldado legalmente aqui no Brasil desde 1940.
faith-based
Acho que todas as
organizations
pessoas aqui
and
presentes têm
organized
consciência do
civil
desafio que é
society.
estabelecer esse debate
Everybody
qualificado aqui
here
no Brasil e em
knows
outros países
how
da América
difficult it
Latina.
is to have
Mas
such
não
a
é um desafio qual
qualified
a gente vai
debate in
suportar.
Brazil and
E
Latin
é isso.
America, but we will go ahead with the debate.
Muito obrigada e mais uma vez
Thank you very
pela
much,
participação.
and congratulations for your participation.
Gracias. Aquí tenemos otra pregunta.
Yes, hello. Thanks very much for having us. And we're here from the U.S. government. And because we support the work that we do, you do, that PAHO does, and that Canada has brought to the table. I wanted to echo some of the comments from our colleague from Spain, as we also do a lot of work in advancing HPV vaccines and with the Go Further program that PEPFAR has done. And I particularly am here from our Ministry of Foreign Affairs. As some of you may know, less than a year ago, we created the Global Health Security and Diplomacy Bureau, yet another acronym for all of us to wrap our heads around. And I wanted to flag that here because we did it to leverage and some of the work that we have done and deeper understanding around lessons learned in HIV, particularly because, of course, PEPFAR is now housed within that larger bureau. And something that we're seeing a lot of, and I'm curious to know if some of your participants are addressing this as well, which, as I'm sure you know, in the early days of HIV, and it continues now, is deep misinformation that seeps everywhere and makes the implementation of our programs increasingly difficult. And we are tracking that as well on in sexual reproductive health. And I'm keen to know if any of your participants have some lessons learned or ways that they're approaching that misinformation, disinformation, tracking where it comes from, and better ways to address it. Thank you.
Thank you. Seguimos.
Thank you. So we have, tenemos aquí otra pregunta de los participantes virtuales para la doctora Eva Cerrulla. Desde Amazonas, Venezuela, pregunta a esta persona, ¿han contemplado las poblaciones indígenas? También carecen de todos estos elementos que la doctora Susan ha mencionado, siendo un grupo muy vulnerable.
Yo quería empezar agradeciendo todas las preguntas que están en el chat. Son preguntas muy interesantes. Voy a responder de los indígenas y no puedo dejar de responder una sobre clima. Cuando presentamos un informe que en su momento original tuvo como 60 páginas y tuvimos que bajarla a casi 12 y había cerca de 100 referencias y tuvimos que bajar casi 50, siempre que lo presento, más de un año desde que lo empezamos a hacer, la impresión es que no hablamos de todo. Así que me encanta tener una pregunta sobre indígenas. Nosotros somos una región muy especial y hay pueblos originarios, como muchos prefieren ser llamados hoy, se llama más pueblos originarios o poblaciones nativas, como pasa en Bolivia, que hay más de 30 etnias. Son de verdad un grupo especial que muchas veces suma vulnerabilidades. Son vulnerabilidades que se dan por su localización geográfica, Otra vez tomo mi propio
They're
país como
vulnerable because
Brasil,
of their geographic
y nosotros
location,
tuvimos
for
los
example, in my
problemas
country, in
siempre
Brazil,
con los
and
indígenas de las áreas
we
centrales de Brasil
had a
por los
situation
temas
with an
de
indigenous
migración,
group in the
pero
central
podríamos
of
tomar los que
Brazil.
están en Chocó,
But
los
this
que
has
están en
also
Chaco,
happened
en
with
varias
other
regiones
areas like El
locales
Chaco,
de toda la América
and
Latina.
not just in our
Sin
country,
hablar de
but
las
throughout
regiones
Latin
andinas.
America, without
Esa pregunta
mentioning the
podría ser
Andean
después
region.
por varios
So this is a
casos
question that Carmen could
nosotros ahí,
also
ese es un
answer
tema que
because
discutimos mucho.
it is something that
Este
we
OPS,
have
usted sabe
discussed
que
at
tenemos una
length.
otra área, otro
Bajo has
departamento
another
que
area,
trabaja
another
especialmente
department
sobre
which
determinantes
works
sociales de la
especially
salud.
on the social
Y hemos
determinants
trabajado todo
of
el
health.
tiempo
And
para cubrir
we have
esos
worked
temas, la
together to
atención
address
que
issues
de alguna
related
manera
to
llamamos
the
culturalmente
services
adaptada,
which
como
we
hacemos con el
call
pasto, esa
culturally
atención,
adapted
pero
services. And this
especialmente en
includes
la localización
childbirth,
territorial.
among other
Hoy, dentro del
services. But
departamento
we
del
look at,
sistema de servicio de salud, tenemos
from
una
our vantage
preocupación
point, from our
especial con
department,
esos
we
territorios,
are
ese
especially
espacio de los
interested
indígenas,
in
sin olvidar de
indigenous
tener
groups.
ese abordaje intercultural.
And we do
Así que
believe
me
that
encanta que
we
venga desde
do need to have
Venezuela,
that
el primer
intercultural
lugar
approach. So I'm
donde
happy to
tenemos una
receive the question
población
from Venezuela,
indígena con
which is a
mucho
country which
ese
also
tema,
has an indigenous
el tema de la
population,
migración,
which
de ser
has many
mujeres,
issues,
estar en
migration,
muchas veces
status
expuestos
as
a
women,
lugares donde
being
no hay
often
servicios de
exposed
salud.
in places
Y
where there
ahora me
are
paso
no
a lo del
healthcare
clima.
services. And now let me talk about climate.
Ustedes saben que en ese momento hay como 5 o
You may
6
know that
emergencias
right now there are
dentro de la
5 or
región.
6 different
Y esas
emergencies
emergencias
in the
climáticas,
region. And these climate
desafortunadamente,
emergencies,
serán cada
unfortunately,
vez más comunes y
are
llevarán
becoming
a
more
más
frequent,
crisis
more common,
humanitarias.
and
En
are the
esos
cause of
momentos de
more
crisis
humanitarian
humanitarias es
crises.
fundamental
And in that
conocer
context
dentro
of a
de OPS,
humanitarian crisis,
dentro
it's
de
important to
OMS,
know that in
tenemos
PAHO,
todo
in
un cúmulo
WHO,
de
we
herramientas
have a full
y
set
evidencias sobre
of
cómo
tools
proceder para ayudar a
and
esas
evidence
mujeres. Les voy a dar
we
un
can
ejemplo
harness
muy
to
sencillo.
help these
Acaba de
women. Let me
pasar
give you
en
a very
Brasil
simple
una
example.
emergencia muy
Brazil just
importante en el sur
experienced
de
a
Brasil
major
con
emergency in the south
inundaciones muy
with
importantes.
severe
Y
flooding.
un acto que sería simple es que
And something that may seem
separar
simple,
los
which
lugares que
is
se abrigan a las
identifying
personas desabrigadas, no se
shelters
hizo. Entonces,
and
al investigarlo
separating
recibimos denuncias
populations
de
within
violencia
shelters.
sexual en
So
estos
we
lugares.
found, or
Y
we
claro,
received
inmediatamente la doctora
reports
Renata
of
y todo
sexual
el equipo de
violence
mujeres
taking
de
place
salud
in those
estaban
shelters.
en
And
Rio
Dr.
Grande do
Renata
Sul,
and other
estaba
health
en el
personnel
lugar
in
que
Rio
se
Grande do Sul
produjo
on
toda
site
esta
where
emergencia
the
y tomó
emergency
las
happened,
medidas. Y desde la
took
cooperación
steps to
técnica con
address it.
Brasil, nosotros
And through our
aportamos
technical cooperation
elementos.
with Brazil,
Clima
we were
es un
also able to offer
determinante
support.
en la salud.
Climate is a major
Los
determinant of
servicios
health,
de salud
and
pueden ser,
health
pueden
services
mitigar los
can
efectos de eso
mitigate
si
the
usan
impact
todas las
of
herramientas de
such
conocimiento
situations
y
if we
evidencia
avail
que hemos
ourselves of all the
acumulado.
tools, all
Así
the
que es
knowledge,
otra
and all the
pregunta que creo
evidence
que
we have
deberemos
at
discutir
hand. So it
en
is
algún
something
momento.
you need
Capaz
to
que
explore
algún
together.
webinar
Hopefully, we
sobre
will have
clima y
a
salud
webinar
reproductiva.
on climate
Y
and
perinatal,
maternal,
que sí, ya es
sexual,
algo
and
que venimos
reproductive, and
haciendo una
perinatal health,
discusión
because it is
importante
something which
de
has
las
been part
evidencias, de los
of our
cambios
discussion. We
y de
see
las
it in the evidence.
repercusiones
It
en la
is
salud
part
de la
of
mujer,
changes
en la
and
salud de la madre, en la
has an
salud
impact
de
on the
los
health of
bebés.
women, of mothers, and of newborns. Thank you very much.
Entonces ahora ya pasaríamos a James
So now
para el
we'll
cierre. No,
go to
¿tenemos una pregunta
James.
más?
No, we
tenemos
have
ahora un video.
a
Ay,
video.
Sí. Entonces el video que vamos a ver a
So the video we're
continuación
going to see
muestra un breve
next
resumen de
offers
una de las
us
experiencias de trabajo
a
conjunto en el marco del
summary of one of the
fortalecimiento
joint
de los servicios de
experiences we
salud sexual y
had in
reproductiva en
strengthening
Honduras.
sexual and reproductive health
También es una
services in
acción enmarcada
Honduras. It is an
dentro de la
action
alianza del
which is
gobierno de Canadá
framed in
con
the
OPS.
as,
Gracias.
as part of the partnership between the Canadian government and PAHO.
Nosotros somos el principal hospital de
We are the
referencia a nivel
main
nacional
reference
y nosotros
hospital
pues
at the
siempre andamos
national
buscando
level,
la
and we're
forma de
always
darles
looking
la
for
mejor
ways
atención
to
de
provide the
calidad, pero
best
además los datos que
quality of
nosotros
our Additionally, the data we obtain serves as a reference for the Ministry of Health to make decisions and improvements in the quality of healthcare.
El CIPLUS es el Sistema Informático Perinatal.
The SIP is the Perinatal Information System.
Del CLAP, en el cual hacemos el registro de las atenciones que se le da a la mujer,
We record the care provided to women during pregnancy, childbirth, and there's also a section for neonatal care.
Entonces acá trabajan los muchachos que llenan los expedientes y esas computadoras.
So this is where they fill out the records. These are SIP computers. We're in the Batres classroom in the teaching hospital. And the space is used for data entry and for quality control of the perinatal information system. So the teaching hospital currently generates data related to pregnancy, childbirth, and abortion. As a reference hospital, we have a large number of patients who are dealing with miscarriage situations. 80% of these cases are managed through medical procedures.
Actualmente contamos con una de las bases más
Currently, we
grandes del
have one of the
país.
largest databases in the country. We also have the most solid database. It's a database that has very few discrepancies in the data. I would highlight the use of the SIP in the teaching hospital as one of the best standardized and well-programmed methods for maintaining a record of high-quality data.
Tenemos planificado ya
We have planned training for resident doctors who will be entering the postgraduate program this year. The simulators also are very useful, and Bajo has offered assistance together with CLAP to improve the workshops we offer. Residents have rotating internships in gynecology and obstetrics every 3 months, and simulators are also very useful for their training.
The main
advantages of being part of the network include having the support of an international organization that is consistently working on improvements in the quality of healthcare, especially in the field of sexual and reproductive health. They assist us in improving data collection and ensuring the quality of data we use to enhance our practices, patient care, medical decision-making, and everything we knew to ensure the high-quality care we want to provide.
Bueno, ahora sí invito al doctor Fitzgerald.
Now I invite Dr. Fitzgerald, or Susana rather. I just wanted to give special thanks to our partners in this process. I've said this a few times, we cannot do this alone. And throughout the process, a number of regional mechanisms like the Working Group for the Reduction of Maternal Mortality, the Neonatal Partnership, and other partners like UNFPA, UNICEF, Voz Feminista, and so many others. When I name them, I always feel that I'm forgetting many more, but they have helped us, and we continue to work together in all available spaces. And also, we receive support from Canada for our project, and we also work with USAID. We have a project in sexual and reproductive health with them, and also we work with other partners. So thank you to our partners for depositing their trust in Bajo and in the Latin American Center for Perinatology and Women's Sexual and Reproductive Health, and helping us promote our agenda on sexual and reproductive rights. Thank you so much. Thank you, Suzanne, and all that's left for me to do is close this event, offer some final remarks, and I think you would agree with me if I say that what we have seen here this morning reflects a diversity of experience, a richness that speaks to the installed capacity in the countries of the region and how they're equipped to take on the challenge of expanding access to sexual and reproductive health services as a right, to overcome the barriers we've heard about from a number of participants in different countries, be they geographic, financial, or cultural barriers, things as basic as the lack of access to contraceptives, and more complex issues like the governance of the national plans and programs, and the need to reduce inequality when it comes to access and take on social challenges that impede access for vulnerable populations. Another thing that I'm sure you agree on is the importance of adolescent pregnancy. It's come up in almost every presentation today. As our director said, it is an issue which is closely related to the high mortality rate in the Americas as a region. So on this International Day of Action for the Health of Women, I think it is a good time to redouble efforts and national plans and policies, stressing the importance of the word action. It's important for us to move from discussing plans to taking action. And that is something which will be ongoing this year. We will have another important event on the 18th of June on maternal mortality. So we will invite you to join us. Given the importance of this issue, the rate is alarming in the Americas currently, and the topics we have been discussing here are closely linked to that issue. So this discussion will continue, and we will invite you to join us for that. So on behalf of our director, Dr. Jadavas Barbosa, I wanted to thank Canada, Jillian and Haiti. Thank you on behalf of PAHO for all the support you have provided us for this initiative in recent years. Also, to our participating countries and panelists, Renata, who is still with us, and Maria del Carmen, the Executive Secretary. And we also thank the Minister of Health of Honduras for her very active participation. And I will thank Spain again for being here with us and for speaking on this very important subject that is related to women's health. And I thank everyone here for joining us in the room or online to share your experiences, and our partners in academia and civil society. I also, recognizing the diversity of our region with our different languages, we thank the interpreters for their assistance, and also thank Melina for her excellent role as moderator. So we thank LAP through the person of Dr. Suzanne Cerrulla and the rest of the team, advisors and focal points as well. So thank you to the entire PAHO team. Thank you for your support. So I hope we leave this room with renewed energy, and we look forward to seeing you soon on the 18th of June to discuss the other important topic we'd like to explore with you, which is maternal mortality. Thank you.
Bueno, antes de que se vayan, los queremos invitar. Before you leave, we'd like to invite you to join us for refreshments on the second floor. Please come and have some coffee or other refreshments before you go back to work.
Hace 19 años que yo soy voluntaria.
Las pacientes ya se ponen bien.
El servicio de telemedicina consiste primero en la captación de embarazadas que residen en estos lugares.
Se les solicita a la voluntaria de salud
y a la paciente que tenga acceso de la red para recibir esta llamada.
Tenemos un grupo de chat, nos informa si hay algún signo de alarma o algún inconveniente con alguna embarazada.
Hasta que ya Dios me diga, venga para acá, yo creo que voy a dejar de ser voluntaria.
Fue muy bonito porque es una experiencia que cada mujer vive. Es un momento muy especial ver el milagro que Dios hace.
El hecho de tener a su bebé desde el primer minuto de vida les ha ayudado a ellas psicológicamente a sentirse seguras, a saber que su bebé está bien.
Estamos teniendo en nuestras manos una vida nueva que depende de nuestros cuidados y del empeño que nosotros tengamos para poder recibir a ese bebé de la mejor manera.